Okay, now we are going to do the next topic, which is IgA nephropathy. This is also very much important, guys. What happens in it? Patient has proteinuria that is minimal to nephrotic range. Yes, now we have to know in IgA nephropathy, patient may present with the nephrotic range hematuria that is, sorry, proteinuria that is greater than 3 grams per day. So we have to know this. Please don't forget. Okay, IgA nephropathy. It can present with the nephritic plus nephrotic uh, symptoms. Now, hematuria, glomerular hematuria, that is microscopic. Yes, that is pretty much normal. Yes, other thing is macroscopic growth after infection. So, IgA nephropathy can happen after infection, right? And patient may present with the gross hematuria, right? And thirdly, I positive IgA staining on the kidney biopsy. We do the biopsy and we see the positive staining, right? Now, general consideration, mostly what is IgA nephropathy? This is called as Burgess disease, right? It is primarily a renal disease of IgA deposition in the glomerular mesentery. Basically, what happens? There is a deposition of the IgA deposition in the glomerular mesentery. The inciting cause is unknown. We don't know the exact cause, but likely due to the deficient O-linked glycosylation of IgA subclass 1 molecule. So very much high-tech thing. So no need to remember it. So IgA nephropathy can be primarily a renal limited disease, only involve the kidneys, or it can be secondary to the hepatic. There primarily renal cause, and there are other causes as well. For example, hepatic causes, that is cirrhosis. Number two, celiac disease, infections such as HIV, CMV. Susceptibility to IgA nephropathy is inheritable, and there are some secondary causes, and we talked about it: hepatic causes and IgA cause, HIV, and cytomegalovirus. Okay, the most common cause is primary glomerular disease worldwide, and particularly in Asia, and the most commonly seen in the children and younger patients. In the children and younger patients in Asia, patient presents with this condition, that is primary. And yes, more common in the males. Very much important. 3 is to 1 ratio, I guess. 3 is to 1 ratio. Okay, now clinical findings. Now, what is the classical picture of it? Is, yes, very much important, guys. Please don't forget, an episode of gross hematuria. Patient is absolutely normal, very much fine. Suddenly, he presents with episode of gross hematuria. Now, it is associated with mucosal viral infection, infection of the mucosa due to the viruses, often upper respiratory tract infection. Like now, they're saying the most common cause or the most common presentation or the most classical presentation of IgA nephropathy is episodic gross hematuria. That is a boy, that is a young adult, and he's male, and he presents, he was having the past, like for 2 to 3 days back, he was having viral infection. That was not bacterial but viral infection, throat infection or mucosal infection. Okay, and now he presents after 3 days. He went to the toilet and he saw that there was a gross hematuria, and he was so much surprised, and he was so much worried. Now they say that the urine becomes red or smoky, smoke colored 1 to 2 days after illness. After 1 to 2 days, it becomes cola colored urine. So it is called as synpharyngitic presentation. Okay, he needs my assistance, guys. Now you talk to each other. I'm coming. Uh, okay, now we were talking about the IgA nephropathy. So we talked about that the patient will present with an episode of gross hematuria after any viral infection, upper respiratory mostly, and he may have the urine color, which is cola color, after 1 to 2 day of illness. And this is important term, which is called as synpharyngitic presentation. After 1 to 2 days of illness, smoky color urine, it is called as synpharyngitic presentation. And in contradistinction to the latent period seen in post-streptococcal. Okay, that's very good. IgA nephropathy, post-streptococcal, post-infectious nephropathy, difference after 1 to 2 day. In IgA nephropathy, the term is called as synpharyngitic presentation, but in post-infectious, it is a latent period. It happens after 1 to 3 weeks. Okay, they say IgA nephropathy can also present anywhere along the nephritic spectrum, from asymptomatic microscopic hematuria to rapidly progressive glomerulonephritis. Figure 2 to 4, where is that? we've read it already. Yes, 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 we've read it. Uh, okay, rarely nephrotic syndrome may be present. I told you already. No serological test helps in diagnosis of this case, but IgA subclass 1 testing may be possibility in the future. So in the future, they're doing the research, they're doing the work on it, having lots of trials, and patient they will see that they have seen that serum IgA subclass 1 it is present, and now testing are happening on them, and in future we will see it in maybe CMD 2025. Okay, serum complements normal, very much important. The typical pattern of injury seen on the kidney biopsy, yes, yes, please find it. Focal glomerulonephritis with mesangial proliferation on the microscopy, sorry, in the biopsy, focal glomerulonephritis with mesangial proliferation. And now immunofluorescence, what is that there? There is diffuse mesangial IgA and C3 deposition. Yes, Dr. Azim, again, need a favor. Please only write down this microscopic features of every glomerulonephritis. Okay, only that, nothing else, only this biopsy finding. Okay, now we do the treatment. All right, good. Treatment is the disease course of primary IgA nephropathy varies. Yes, we know. Treatment approaches, it needs to be tailored to the risk for progression. Yes, basically is symptomatic treatment, supportive treatment. Now we talk about the low risk patient and high risk patients. In low risk patients, there will be low progression of disease, there will be no hypertension, normal GFR, minimal proteinuria. We should monitor them annually. Okay, no treatment. Now the high risk patients, what should we do with the high risk patients who have proteinuria greater than 1 grams per day? One, decreased GFR2 or hypertension 3 or any combination of these conditions. Now what we have to do, we have to give them a pharmacological therapy, that is ACEs or ARBs. Okay, it's a gold standard treatment, and it should be titrated to reduce proteinuria because it has the reduction in the proteinuria to lesser than 1 grams per day, and control of hypertension the range of, this is very nice information. Yes, the target of the goal of treatment should be proteinuria should be lesser than 1 grams per day, and blood pressure control should be from 125 by 75 to 130 by 80. Okay, this should be our goal of treatment. Now, this is the addition of corticosteroids, methylprednisolone grams per day, IV for 3 days during month 1, month 3, and month 5. This is one thing. Plus prednisolone in a dosage of 0.5 mg per kg orally every other day for 6 months in the patient with GFR greater than 50 mils per minute per 1.73 meters square and persistent proteinuria 1 grams greater than 1 class has been reduced the proteinuria. Little durable risk of infection, hyperglycemia. All right. So now they say that now they have given the trial to this patient with the corticosteroids. So the corticosteroids they have given first methylprednisolone. We know we give it as a pulse form for the three days, and they have given it month 1, month 3, month 5. One thing. Now oral prednisolone, and that was 0.5. Normally we give 1 mg per kg. Here they're giving 0.5 for continuous 6 months. They have given it, but the criteria in which patients who have GFR greater than 50, because for the corticosteroids, GFR should be greater, I mean, it's of good value, greater than 550 by minute, and they should be persistent proteinuria greater than 1 gram per day. They say that they have done this thing, it has reduced the proteinuria, but you know there are side effects of these medications, these corticosteroids. So they say that the patient they presented with the risk of infection because immunity was lowered in these patients, one, and number two, they presented with the hyperglycemia. Okay, now we do the chemotherapy, that is immunosuppressive therapy, that is azathioprine and mycophenolate mofetil. Okay, these two things were tried, and they say that they basically we are using all these things in the high risk patients, and they say that that their role is not, I mean, that much like helpful, and we don't use that. Okay, for this is for the rare patients in which there was progression of the disease, that is rapidly progressive disease. There was formation of the crescents. Now they tried cyclophosphamide, that is immunosuppressant, and corticosteroids. We have to consider them. This is a question, you know. This is a question again has come again. They say that the patient has rapidly progressive glomerulonephritis with the crescent formation, and now what we have to do, basically, patient was known case of IgA nephropathy. Now we have to give them a trial of cyclophosphamide and corticosteroid. Just Dr. Azim, just put the high yield these kind of things in your notes, which you will share, inshallah. Okay, next is now what is the last resort? We go with the renal transplantation. It is an excellent option for end-stage renal disease. Yes, when there's no cure, go with it. And but you know this, there's a harm to it. The recurrent disease again happened in these patients with the transplant, and the rate was, I mean, percentage was pretty much high. That is 30% after 5 to 10 years of post transplant. Okay, recurrent disease. Okay, so that is not that much harmful disease, because yes, leave it. Now, what is the prognosis? Prognosis actually, one third of the patients experience spontaneous clinical remission. One third patient remission. Progress, the rest patients progression to end stage occur 20 to 40% of patients. Okay, this, you know, these kind of percentage, you know, the September exam, there were some percentages regarding, I think so, chronic renal failure. I'm not sure about it, and they were asking that how much happened, this and that. So yes, we can just have a look to it. So one third patient remission, 20 to 40% patients progression to end-stage renal disease. Okay, yes, we have to know. Okay, the remaining patients, they go into the chronic microscopic hematuria. So three things, and a stable serum creatinine. Okay, please, yes, this Dr. Azim, please write down these things. Okay, that will help you so much for your exam as well, right? Okay, now next they say that most unfavorable prognosis. Now another thing, what are the poor prognostic factors of IgA nephropathy? Again, asked question. That is one is hypertension. Number two is tubulointerstitial fibrosis. This was the question, tubulointerstitial fibrosis. And number three, glomerulosclerosis and glomerular crescent on the biopsy. They had emphasized on the crescent. Okay. And abnormal GFR in the presentation. Yes, please, Dr. Azim. Yes, please. Note down these points as well. Okay, now we are.
Yes, ma'am.
Excellent, excellent, Dr. Azim, excellent.